morning, everyone, particularly the one I didn't have a chance to greet this morning. It's my privilege this morning to introduce this topic from the patient perspective on health inequalities and rare diseases in Europe on the occasion of this fourth Rare Disease Day. And I just take this occasion to repeat that everything is live on internet through the EURORDIS website and Rare Disease Day website, but it is also recorded. So you or your colleagues, or if you want to make it known to people around you, it will still be available in the coming days. So the approach of my presentation will be what rare disease patients and families are telling us about access to diagnosis, to healthcare and social services, and I will insist on that, and on orphan drugs. And to do that, I will share with you some testimonies which have been submitted by patients and... Are you making sign to me? Or? That's a good point. Thank you. Okay. So I will use testimonies which have been submitted by patients and families, but also results of surveys. Why do we need patient survey? Because we need to support patient anecdotes and patient group views with robust quantitative data based on patients' real life experience. And these surveys provide evidence on patient needs for adapted healthcare policy and services. Also, these findings help shape the EU policy on rare diseases, as well as in the member states at the time when we are developing the national plans on rare diseases. We have a series of surveys which are called EURORDIS Care surveys, and to describe and compare patients' experience and expectations, we run two surveys, one on access to diagnosis and one on access to health services with a variety of significantly relevant rare diseases in Europe. Our approach is quite unique because although initially a lot of academic people told us you will never be able to do that, it's impossible to do a survey in 12 or 15 languages across Europe for such rare diseases. Yes, it is doable. It is doable by using scientific methodology, and we did that with the support of two INSERM units. The INSERM is the French National Institute for Research, for Medical Research in France. And so we worked with the biostatistic and biomathematic units and the public health research unit to develop these methodologies, and then to work through the network of patients' organization with a randomization of their database of members in order to access to them. After these two surveys, we published all the results, consolidated results of these surveys on a book called The Voice of 12,000 Patients. You will understand why 12,000 in a moment. And that was launched at the Rare Disease Day 2 years ago in a building just in front of us here at the Berlaymont building with the Commissioner for Health, Mrs. Androulia Vassiliou. But as much important or even more, the results have been shared with every patient groups which have participated to the survey, and also to their European federations, and also with the national alliances, with presentation of results by disease, by countries, and etc., in order to disseminate that as broadly as possible and make it a tool for advocacy for the patients. You have this book available on the tables outside if you don't have it already. The Voice of 12,000 Patients is the consolidation of two surveys, as I mentioned. The first one, on access to diagnosis, was performed from 2003 to 2006, and almost 6,000 patients and families participated into it for 8 different rare diseases involving 70 patient groups across 16 countries, and for that we needed to do it in 12 languages. The second one, on access to medical and social services, was performed in 2006-2008, and that collected another 6,000 questionnaires from patients and families for 16 rare diseases involving 130 patient groups from 22 countries and 15 languages. If I look stupid when I look at the screen over there doing like that, it's because here on my screen I don't have the slides, okay? So that you understand. So first, going through the results now. Access to diagnosis. I will not go into details. It's really some of the key findings, key messages for you on access to diagnosis. After that, access to health and social services, and orphan drugs at the end. Access to diagnosis. 25% of patients reported waiting between 5 to 30 years from the time of first symptoms to confirmatory diagnosis. 40% of patients were initially misdiagnosed, which leads obviously to severe consequences of inappropriate care and sometimes surgery, which they didn't need, or psychological treatment, psychiatric treatment, which they didn't need. 25% of the patients had to travel to another part of their country to access the diagnosis, and 2% of them had to travel abroad in another country. And that takes us back to the presentation of this morning on cross-border healthcare. So you remember that was mentioned to us that the average is 1% in Europe. So for rare diseases, we know at least from that 2% to access diagnosis needs to travel. 33% of the patients for their diagnosis was announced in an unsatisfactory terms, and for 12% it was done in unacceptable ways. We have plenty of testimonies of doctors saying, for instance, at the time when the baby is born, saying to the mother, forget about this one, just do another one. That's probably the most violent thing I ever heard in that situation. Genetic counseling was provided in 50% of the cases only. In 25% of the cases, the genetic nature of the disease was communicated, strangely, because 80% of our diseases have a genetic origins, which is well identified. I'd like to share with you capsules of 3 testimonies. Katarina says, I waited 21 years to be diagnosed with alpha-1 antitrypsin deficiency. It shouldn't take that time. A doctor said to Catherine, you look too healthy to have osteogenesis imperfecta. Yes, too bad. She was diagnosed with osteogenesis imperfecta, but at 19 years, when she should have be diagnosed when she was a young child. They told me I must be good at fooling the psychiatrist, reports to us Nelly, which in fact was diagnosed with mixed connected tissue disease in the UK. Access to healthcare services. Patients with rare diseases require, on the average, 9 different essential medical services during a 2-year period. And that reflects the complexity of the disease, and this is why we need multidisciplinary centers of care for these diseases. But for 26% of the patients, they reported difficult, very difficult, or impossible access to services, and a key critical point is the lack of referral as a main barrier to access these medical services. 10% of patients reported that these essential services poorly met their expectation or didn't meet it at all. And that was when they were able to find it. Another example of PKU, and we heard today the testimony from Cluj, Romania, and this one is from Mariana in Romania. To this day, the PKU patients who belong to the PKU center in Cluj, which was also mentioned by Carmen, are not monitored. To determine their level of phenylalanine, we have to travel 200 kilometers. In France, a doctor called Antonio Chisberea, an expert in neuromuscular diseases, working in a center in Hendaye, in France, but close to the Spanish frontier, says when French patients at the center are reimbursed by the French Social Security, we have, on the other hand, 10 to 15% of our patients with neuromuscular diseases who come from Spain, which is just a few kilometers away from Hendaye. I see them in outpatient consultation, but they cannot stay at the center because there is no cross-border healthcare agreement to cover their cost between Spain and France. I now move to social services and financial aspects. 29% of the patients required the assistance of a social worker in the last 12 months. And obviously, that during all their life, they're going to need regularly these services of social worker. While the majority of the patients reported an easy or very easy access, more than 1/3 met difficulties or could not meet one social worker at all. 50% of the patients or the families are saying that when they seek social services, their expectations were not met or met somewhat. So it's 1 out of 2 which is not satisfied with their access to the social services when they are able to have that kind of access. To illustrate that situation, we have that testimony from the UK. Elia is a 6P25 dilation patient requiring at least 2 hospital appointments per month, and that results in a lot of travel between Kent and London. The mother says, we have lost count of the number of times a doctor or other professional has asked us to begin at the beginning as they try to understand, repeating always the same story indeed, as most of us have experienced already. And then she concludes by saying, parents of disabled children often have to fight for even the most basic services, but it seems that those with rare diseases have to struggle even more. I'd like to add to this testimony something that I do rarely, my own testimony. And I think I owe that to my daughter today, who is turning 21 years. Although I'm the chief executive of this European Organization for Rare Disease, although I've been one of the founders of it and of the National Alliance on Rare Disease, although I have been for 10 years a board member of the Cystic Fibrosis Foundation, so I'm supposed to know the system a little bit, right? But even in that situation, my daughter was 21 years, it took her 1 year to solve a problem to be covered 100% of her expense care. From the moment she turned considered as child and attached to the parents, from the moment she's adult. Why that? We had to prove twice to fill up the same dossier with the hospital to explain that she has cystic fibrosis. Strangely, it has not disappeared in 6 months. She had to pay 700 last week. That was just last week. She had to pay 700 euros out of her pocket. That's what she has for 3 months to live with from her parents. That to pay for the consultation of that day. If not, she had to cancel the meetings with the doctors that she had that day, the consultation, and come back 2 months later. She couldn't afford that in terms of health. We had to pay as parents thousands of euros to the physical therapist because she was not covered during that period, and we're not sure we will recoup it. The pharmacy is providing the medicines every month as a charity, and they hope they will recoup it from the social security system. And we did everything right from the beginning. And it was very easy to access to the social worker. That's not the problem. It's just that after that, the system doesn't work. And that's France, where there is a national plan on rare disease, where there is strong patient groups and system on cystic fibrosis. So that's my story, and I'm not saying that to tell you about me. I don't care about that. But when I cry, it's not about me. It's when I think about the others who don't have the chance to know as much as I know and have even less access than that. Now I continue to move to say how much these social services are not adequate to the patient needs. And this is what patients are saying. The more specific you have needs, the less satisfied you are with the assistance. So that's really specific to rare diseases, because all needs, the rarer, the more complex, the more difficult situation, then the more we're going to need some adjustment of that. But then we're less obviously satisfied with the assistance. And that works both for the information on social, legal, and financial rights. As you can see, the bright orange and light orange part here, but also for the assistance for exceptional financial support, such as purchase of a wheelchair, home adaptation, medical consultation, everything that makes your life simply possible, that allows you to move around and to live in society or in family or to go to school or to work. Just one testimony, and I know this testimony is from Ukraine, so we have plenty from European Union, but we like this one because we like very much Vitaly. He's a wonderful father fighting over there to change the situation. And what Vitaly is saying is that he's engaged since 2008 in administrative battles and lawsuits to obtain the reimbursement of an electric wheelchair for his daughter. Yulia. She's living in Ukraine and suffers from spinal muscular atrophy. And you can see that she already has the electric wheelchair because the father can afford it. But what the father cannot stand is that the other families who cannot afford it don't have the same capacity to buy it. And he wants to be reimbursed. And he's right, because this is how things should be. So Vitaly has won twice the court case against the Ministry of Social Affairs. But they have appealed twice, believe it or not, because they don't want to pay. But he's not giving up. And he will take it, as he says, I will go as far as I can. The law has to change, and we will help him, even if he has to go to the European Courts of Human Rights. Too long to explain, but yeah. Now I'd like to cover the financial burden. Financial burden is often not discussed in our situation. But in this room, I'm sure, we have plenty of stories that we could tell and share. 29% of respondents reported they had to reduce or stop professional activity as a result of their disease. But in addition, 30% report that in their family someone had to stop working, the mother, the father, or a companion. So overall, it means that in Europe today, for the 30 million families affected, at least 60% of these families are living with rare diseases, have lower income as a result of the disease. 16% of the patients, in addition, had to move house in order to move to a closer centers of expertise, or any other kind of better services for them, and that has a cost. So they have lower incomes, but they have more expenses. That's only one expense. We have this testimony from Fiona. She says, before I had Jonathan, I was a graduated biochemist with 3 years experience working in a pathology laboratory. If I had been able to stay at work, I estimate I could reasonably have earned £250,000 over the 16 years of growth of my son. In fact, during that period, she received a carer's allowance, which turns around £33,000, which means something like 20 pence an hour for taking care of a son who is sick. Exclusion is another main problem in accessing care for people with rare diseases. Based on their experience, 18% of them report that they have been rejected by health professionals because of their disease. And the main reason for that rejection is the complexity of their disease for 69% of them, rather than linked to themselves, 31%. And the reason links to themselves can be things like communication difficulties, can be their appearance, or can be their behavior. We have this interesting testimony, which I like very much, from Kairia, because she lives both in the UK and in Saudi Arabia, right in the middle of the hotspot at the moment, right, when things are moving. I am a 38-year-old single. I work in a place that falls below my dreams, and I am treated with disrespect. Pretty strong word, right? At all levels, from almost everyone in the society, just because of a rare disease that I was given to live with. But Kairia is not a victim. Kairia is living in the UK and Saudi Arabia. She's diagnosed with congenital HHOC-form erythroderma and ectodermal dysplasia, which affects the skin, the teeth, the hair, the nails. And she was called the red girl by kids and adults, even by adults at school. But she overcome all that. She's brave. And she graduated from medical school with honors. But you know what? She's denied to have an academic position because of her appearance. Now I'd like to move to the last survey on orphan drugs, access to orphan drugs. I will go pretty quickly on that one. We performed last year our 5th survey on access to orphan drugs in Europe, but this one was performed in a different way through the national alliances. So again, through the patient groups to see what is the perception of availability by the patient groups. And EURORDIS brought the methodology and the analysis into it. The survey was conducted in partnership with 10 national alliances in Belgium, first Denmark, France, Greece, Hungary, Italy, Netherlands, Romania, Spain, and Sweden. And we looked at the situation of 60 orphan drugs which are approved to be on the market. And altogether, when you take the targeted population of the 60 orphan drugs in these 10 countries, it means potentially 2.2 million patients in a population of 256 million citizens in these 10 countries. So I'll not present you all the detailed results, but you can find them on EURORDIS website. But here what you can see is that there is major differences. In some countries, let's say that you have the vast majority of the orphan drugs available, like France, Netherlands, and Denmark. There is some countries where there is a more limited access, like Italy, Hungary, and Belgium. And you can see that in black, it's when it is clear and official that the drug is not available to the patients. When it is in gray, it's that it's very difficult to know if it is accessible or not, because sometimes what it means is that sometimes you can have access through one hospital who take it from abroad, but you don't take it from another hospital, etc. So it's that kind of gray situation. And the situation can get even worse in some other countries. So overall, what it means is that we can see differences from countries, but also by disease area. If we gather together the oncology or the metabolic diseases. But the bottom line, when you look at the last column on your right, so the targeted population, as I said, for these 60 drugs is 2,200,000 patients. We're sure that there is good access for 1.5 million of them, but we're certain there is no access to drugs for about 200,000 of them, and difficult or very difficult access for about 480 of them or 90 of them, 1,000 of them. So what lessons we can derive from that is that for 1 out of 10 patients in EU, they don't have access to drugs which have been officially authorized. That can be up to 30%, 1 in 3 patients, if you take into account this gray area. But the bad news, and that's really bad news for us, because when we do this survey regularly every 2 years, we're really hopeful that it was difficult in the first years, but that after some time the drugs will be progressively available in all EU member states. That doesn't happen. The orphan drug is introduced on the main market and some countries during the first 2 years, and then it stops there. So really, if you're a patient with some of these diseases, living in some of these countries, there is even no hope for the moment that you will get it next year or 2 years from now. What we observe very clearly, I don't go through the figures, but I can tell you the figures support these conclusions, is that the rarer is the disease, the least the access to orphan drugs. And the smaller the countries, the more neglected the patients are. Either because the government, the administration, public administration don't take the right decisions, or because the companies are not asking to provide that drug in that country because there is only 1, 2, or 3, or 4 patients. But there is a good news. The good news, when we look by disease area, is that the better the national healthcare is organized for this rare disease in a country, the better the access, whatever the size of the country. And the more the expensive, the expertise, the more the expertise is available and organized across Europe for that disease, the better the access also. So at least we know how to improve the system. We have a testimony from Margaret to illustrate that. Margaret lives with a pump disease in Ireland. She is 50 years, and she says there is treatment. It was approved in November 2009. It is proving to be effective for patients in the UK that I know, and I know there is about 100 of them in England being treated, but I don't get it here. The administration is not saying no, but simply they are not answering to her, and her health is progressively debilitated. And you can see a testimony video on the iPosy website in Ireland. To conclude, going back to things that have been said already this morning, when you look at the European Charter of Fundamental Rights in Article 35, it says everyone has the right of access to preventive health care, the right to benefit from medical treatment. And the Commission communication on solidarity in health, which was mentioned this morning, reducing health inequalities in the EU, says for some groups the issue of health inequality, including reduced access to adequate health care, can be qualified as one which involves their fundamental rights. And this is where the link is for us between rare diseases, health inequality, and fundamental rights. Thank you very much, and thank you to support for that.